You are welcome to my channel. Today I'll be addressing Pap test or Pap smear and human papillomavirus testing. Why? The reason is simple. We don't want that woman to die of cervical cancer. If precancerous lesions are detected early and treated, she'll be fine. Human papillomavirus is the main enemy here. Screening with human papillomavirus DNA testing is a huge relief and can actually reduce the frequency of Pap testing to human papillomavirus Pap smear testing every 5 years. The importance of this presentation and this testing cannot be overemphasized because it can decrease the death rate associated with cervical cancer. And that will be possible because precancerous lesions will be revealed before becoming invasive. There will be enough time to get rid of the precancerous lesions because it grows very slowly. It may take up to 10 years. And the test will lead to appropriate actions before the disease is deeply rooted and degenerates to stage 4 when there will be no remedy and leading to death within months. The anatomy briefly is such that cervical cancer will originate at the transformation zone, that is, the junction between the squamous epithelium of the ectocervix and the glandular epithelium of the endocervical canal. Two possible tests could be done in three possible ways or three different ways. You can have Pap test, otherwise known as Pap smear, and that is cervical cytology every 3 years. You may choose that option. You can have human papillomavirus DNA testing every 5 years, but you may combine both. And when you combine both, then you have that done every 5 years. Still on Pap test, there is no fixed pattern of screening. Why that? Each province, each state, each country, each health jurisdiction will have what they want and when they want it. And that is why there's no fixed timetable globally. The timetable will be different depending on where you are. Okay, the Pap test is the liquid-based cytology testing, otherwise known as pumperniculair smear or pumperniculair test, which is the conventional testing. Here, what we need is taking the sample from the transitional zone at the endocervical and exocervical regions. Useful to identify squamous cell carcinoma abnormalities, but not so good to identify glandular problems. There may be false positive or false negative outcomes, but that shouldn't stop us from having the screening, right? Existing cancer may not be revealed via the Pap smear. The human papillomavirus testing is done every 5 years. Who is to be screened? All women from age 21 and older should be screened. Some screen from 3 years post the first sexual interaction. Some start between 21 and 25 to age of 69. Some will stop at 70 if they pick normal results in the last 10 years, meaning 3 normal Pap test results in a row. The new guideline. Anybody under 21 is not expected to have Pap smear, but any female 21 to 29 should have screening every 3 years. Under the new guideline, Remember, I've just talked about 21 to 39, right? Now, about 30 to 65. They can have human papillomavirus DNA testing done along with Pap test every 5 years if human papillomavirus result is negative, or they may choose to have only the Pap test every 3 years if they are not consenting to human papillomavirus testing. Under the new guideline, once you are 65, you and your doctor will then reach agreement to stop, but you have to report if you are picking signs of cervical cancer. You can check my channel for full presentation on signs and symptoms of cervical cancer, already published. The frequency of screening is now every 3 years. In the past, it used to be if you have normal cytology consistently, then you will change from yearly to every 3 years. Now, it is every 3 years. Total hysterectomy will not need Pap anymore, but you have to continue Pap testing using the vaginal valve if the cause of the hysterectomy is malignancy. Let me explain. Someone had total hysterectomy, meaning the uterus and the cervix already out. They might have preserved the ovaries or not. What we're concerned about is the uterus and the cervix already out. If the cause of taking the cervix and the uterus out is cancer, then we will continue screening the vaginal vault for Pap testing and human papillomavirus. If it is subtotal hysterectomy, we have to continue screening like the general populace, particularly if there is cervical intraepithelial neoplasia. You may screen more frequently and deviate from the general populace timetable if we are dealing with high-risk lady, meaning diethylstilbestrol in the mother now affecting the female, human immunodeficiency virus, immunosuppressant agent, transplantation or other immunosuppressant, just immunoincompetency generally. That will be the iris. Then you screen more frequently here. Immediate actions could either be colposcopy, and I will make a full presentation on colposcopy later on. If there's malignancy or malignancy is suspected, you can have conization or loop electrosurgical excision procedure to take biopsy for further studies. Results could either be normal, and if that is the case, repeat in the next 3 years. If with human papillomavirus DNA and both are negative, repeat in the next 5 years. Results could be two. That is, it might be that the lab is saying we have inadequate sample. If that is the case, repeat the cytology of Pap test in the next 3 months. The results we may obtain might be atypical squamous cells of undetermined significance. If that is the case, it could either be atypical squamous cells or atypical squamous cells high grade. If the lady is less than 30 years or she has never had human papillomavirus DNA test done, then we have to repeat the cytology or the Pap test in the next 6 months for the first time, right? If the result is negative, then we will repeat the test again in another 6 months, making the second time we're going to repeat it, okay? If the new result from the second 6 months test is greater than or equal to atypical squamous cells of undetermined significance, then we will have colposcopy. If atypical squamous cells of undetermined significancy but with negative results after the second 6 months test, then we will return to routine 3 years. Atypical squamous cells are the most common abnormal Pap test finding. If the lady is greater than 30 years old with atypical squamous cells of undetermined significancy, we must have human papillomavirus DNA testing done. That could be reflex human papillomavirus testing or triage human papillomavirus testing or routine every 5 years or once in lifetime. If the result is positive, then colposcopy should be done. If the result of human papillomavirus is negative, then we'll return to normal Pap testing. Changes leading to ASCOs may be related to human papillomavirus or other infections. If we are picking high-grade atypical squamous cells, then we'll do colposcopy. Whether it has higher risk of being precancerous than atypical squamous cells of undetermined significance. AGUS, that is atypical glandular cells of undetermined significance, might be our result. In that case, it means there's abnormal mucus producing cells without full understanding of what it stands for. So, atypical endocervical cells, atypical endometrial cells, adenocarcinoma in situ, adenocarcinoma found in endocervical canal and extrauterine tissues. Then, we'll have colposcopy with or without endometrial sampling. If the outcome is low-grade squamous intraepithelial lesions, we must have colposcopy and repeat Pap test in 6 months. If the outcome is negative, we repeat again in 6 months. If the outcome is also negative, then we'll return back to routine every 3 years. But if the outcome is greater than or equal to atypical squamous cells of undetermined significancy, then we have to go for colposcopy. If it is high-grade squamous intraepithelial lesion, we must have colposcopy done. These will have higher probability of progressing to a full-blown cancer if not treated immediately. If we are down with squamous cells or malignant changes, we must have colposcopy. Discontinuation of Pap test. This is individualized, meaning we treat each patient based on their health status to determine when to stop either human papillomavirus or the cytology testing. To those who are average risk, meaning they are asymptomatic, they have competent immunity, and they've been having normal reports or results in the last 10 years, or at least 3 normal Pap results in a row, then we can start considering stoppage. In Australia, they will not stop until after 74th birthday. No wonder. Australia has the least mortality in the whole world when it comes to cervical cancer. Like I said earlier, different jurisdictions will set different timetables. Usually, many will choose age 70, that after 70th birthday, no more screening. Some will fix just greater than 69, which is the same as 70, right? But the new guideline is saying anyone greater than 65 with the factors below, that is, they've been having negative human papillomavirus and Pap test in the last 10 years, or 3 normal results in a row, then they should stop. The second group will be the high-risk patients, and in that case, we can't follow the regular starting or stopping time. because they are immunocompetent. For example, someone already exposed in utero to diethyl silvesterol from the mom, or someone with HIV, or those on immunosuppressants, or anyone with transplantation and who must be on immunosuppressants cannot have pap testing to be stopped, just like the the low-risk women. If there is total hysterectomy with cervical excision and the reason for the surgery is not malignancy, then you can stop. But if there's subtotal hysterectomy, meaning the cervix is preserved, even if the reason for the subtotal hysterectomy is not malignancy, we must continue screening at the general populace. Also, if there's total hysterectomy, but with cervical intraepithelial neoplasia, we must continue screening like general populace. There could be early discontinuation if the life expectancy is short. Let me explain. Someone is expected to be having human papillomavirus DNA testing with Pap test cytology, but unfortunately, she has been diagnosed with advanced lung cancer or advanced breast cancer that has metastasized. In that case, you may discontinue screening if the life expectancy is not long anymore. In conclusion, since the problem we are trying to solve is caused primarily by human papillomavirus and some other lesser agents, it is better to have both human papillomavirus DNA testing done with Pap smear. If the result is negative, we will reduce the frequency of testing to every 5 years for both, or in women without immunocompromised condition or conditions, or any other special conditions stated earlier. With that, I've come to the end of this presentation. Please check my channel for cervical cancer signs and symptoms, and also another presentation on the risk factors associated with cervical cancer. We don't want women to be dying because of cervical cancer because it is preventable. Thanks for listening. Remember to share this with all your friends and acquaintances. Remember to subscribe to my channel and give thumbs up. I appreciate it.